I thank you for the chance to speak to you, all of you. I'm sorry I couldn't be here. A lot's going on these days. I've been at the Centers for Disease Control the last 2 days down here in Atlanta, so I was unable to be with you in person this year. In any case, I'd like to ask all of you to hold your questions till the end. I think it'll be a little easier to handle, and we've got quite a bit to cover, so I'm going to roll through these slides, and we're going to try in less than an hour to give you a sense of where CMS is going on health system transformation, to include our value-based purchasing strategies for both to prevent health-associated infections and healthcare-acquired conditions. So with that, if you show the next slide, you'll see a disclaimer. And don't worry about all the fine print. It just says I'm from the government and I'm here to help you. Thank you. I was waiting for that laugh to make sure you're hearing me okay. I am a full-time government employee. I don't have any other conflicts of interest, but I will be presenting the point of view of the Centers for Medicare and Medicaid Services. Let's go to the next slide, which is the three-part aim. And most of you have probably heard of the three-part aim of CMS, established by Don Berwick, our prior administrator. It's basically to provide better care, make it safer, improve quality, improve the patient experience, reduce the per capita cost of care, and reduce unnecessary procedures and medical expenses. And then, of course, to improve population health. And that includes chronic care management, community health status, and reduce healthcare disparity. I'd like to make sure we're all on the same page. We'll go to the next slide here. I mean, it's titled, What's Wrong with U.S. Healthcare Today? Obviously, there's a lot that's right about U.S. healthcare. We're excellent when it comes to treating complex diseases, but in many ways, our healthcare is too costly. It's often inefficient. There's disparities in access to quality. Not everyone in this country, even with the implementation of the Affordable Care Act, still has access to affordable health insurance, and that's a barrier to getting quality care. We often don't have a focus on prevention. The care is fragmented. There's poor information sharing in many cases, and we will talk quite a bit about patient safety and quality. I like to compare that to the aviation industry, which you may know, commercial aviation. In the United States, most years go by without a commercial aviation fatality. And yet in the U.S. healthcare system, we have estimates of up to 200,000 avoidable deaths a year. And frankly, there was testimony before Congress that that number may be too low. It may be almost 400,000 avoidable deaths per year in the healthcare system. We have a payment system that rewards providing services right now under fee-for-service rather than paying for outcomes. But of course, our value-based purchasing programs intend to change that. Often care has been uncoordinated, unaccountable, and we need to make care much more coordinated, much more accountable. So the next slide is a graph, and it's my favorite graph. I think it's worth 1,000 words, and I'll try to explain it in less than 1,000 words. The red bars on this graph, the histogram, are average life expectancy. Over in the far left, you see the left axis there. Japan has the highest life expectancy in the world, about 81 and a half years. And you go all the way almost to the far right to the United States. We're about 5 from the right, the industrialized countries. And you see our life expectancy is somewhere around 77 years. And you can see that there are many countries that have a lot higher life expectancy than us. At the same time, if you look at the blue dots, that's the average per capita cost per person that's spent in the U.S. healthcare system relative to other countries. Don't worry about the absolute figures on the right there because that's changed. This slide actually was put together in 2006. There's a reason I used that 2006 slide. Frankly, if you look at today's numbers, it hasn't changed that much relative to other countries. This is from the U.S. Central Intelligence Agency fact book, and 2006, and that was before the Affordable Care Act was even passed. So this was from a prior administration. The CIA collects this data every year. It's in their fact book. You can get it on the web, and you can see that we spend nearly twice as much as the average of most of the industrialized countries. Right next to us is our neighbor to the south, Cuba, which spends almost a fraction of what we spend on healthcare, and yet their life expectancy is really only about a month different. So something there is we're very good at spending money, but we're not very good at preventing premature death and improving health status. Now let's go on to the next slide, which is another series of bars. And you can also see on this slide, this is, you'd think if we spent that much money on healthcare relative to the rest of the world, the quality of our care would be pretty good. And I set these slides up to show you where we were and give you a historical context of why we're using value-based purchasing. If you look on the far left there, you'll see overall, this was once again a New England Journal of Medicine article back in 2003. And yes, once again, I used the older data to show you where we were. Only 55% of people in our country got the recommended care based on consensus of medical opinion. We were pretty good in breast cancer. 76% got recommended care. But if you look over towards the middle, you'll see that in diabetes care, 45%, less than half of all people, got appropriate diabetes care. Let's go to the next slide because it illustrates that in many cases, quality of care is very variable depending on where you live. Now, once again, this was before the Affordable Care Act. And this was in the Journal of the American Medical Association. You see a map of the United States here, and you see the different colors of gray. The darkest shade of gray is bottom quartile of quality based on HAI measures that were published in this article. And you can see that the southeastern U.S., including Kentucky at that time, was in the bottom quality of care. The bottom quartile. Now, these rankings can change over time. The good news is, as an example, the Georgia Hospital Association had a third effort to improve quality in Georgia hospitals, and they have gone from a ranking of around 48 out of 58 states to a ranking of around 23 out of 50 states now. So if I said 58 states, I apologize. I'm thinking of states and territories. I'm not the only person who's ever made that mistake. But in any case, improvement is possible. So let's go to the next slide now and talk about value-based purchasing and what we want to accomplish. Under our value-based purchasing incentives, we want to incentivize the best care. We want to improve transparency for beneficiaries. We want to transform the Centers for Medicare and Medicaid Services from what had previously been just a passive payer. We had simply paid claims if it was reasonable and necessary, to a more active purchaser of quality health care. And we want to link the payments of our health care to quality outcomes, stimulate efficiencies in care. The next slide shows how we hope over time to transform through the payments system our current healthcare delivery system. If you look over at the left, you'll see the current state. It's centered around healthcare providers and producers. It's driven by volume. It's frankly unsustainable because healthcare costs were going up and up and up. care was fragmented, and it was primarily based on the fee-for-service payment system. As we move through value-based purchasing and are continuing to do so now and in the future, we want to make the care more patient-centered. We want to make it more outcome-driven so that we pay for better outcomes. We need to have a sustainable financial healthcare system. We need to have the care coordinated because coordinated care wastes less money and gives us better outcomes. And down at the right, you can see that we have developed many new payment systems, such as value-based purchasing, ACOs, which are accountable care organizations, and shared savings plans, episodic payments and bundling of payments, medical homes, and care management. And we're focusing on making much more of our data transparent to the consumer. Next slide is transformation of healthcare at the front lines. And basically at the front lines, you need 6 components. You need to measure quality, obviously. You can't improve something that you can't measure. We need to start aligning the payment incentives to improve the quality. We need to improve comparative effectiveness and evidence-based studies as well. And we need to improve health information technology so that we can share information across transitions of care in between providers. We're starting to implement a lot more quality improvement networks and collaboratives and learning networks and train the trainer. And we're training clinicians and multidisciplinary teams to improve healthcare. And more importantly, the answer to improving healthcare is not a CMS. It's with those who are on the front lines of healthcare. So we're looking to those who deliver care to partner with us and partner with their own providers to improve and inform each other as to how to improve healthcare and to share best practices. The next slide, I want to give you some results of some of the things that we are accomplishing, and primarily through the Affordable Care Act. We are seeing the cost growth in healthcare is leveling off. Actually, the rate of healthcare annual increase, healthcare inflation, is the lowest in over 50 years, and that is remarkable. That's primarily due to delivery system changes, we feel. It's not just due to the economy that suffered back in 2008. It's now recovering, but it's due to a lot of the delivery system changes and the way we're delivering healthcare that we can make care more efficient and more affordable. Nevertheless, we still have a lot of variabilities in cost and quality throughout the country, as I showed you on that map earlier. But we are moving the needle in the right direction on national metrics. We are reducing unnecessary readmissions. We are reducing central line, vascular line infections. And we're increasing the value-based payment and accountable care models as we go along. And we're expanding healthcare coverage with the health insurance marketplaces. The next slide is a graph, and it shows how Medicare per capita spending is at historic lows. Over on the right side, let's see 2013, and that begins in 2001. And the blue line is the Medicare per capita growth each year. And as you can see, we started with 9% increases in per capita growth, went down a bit. Don't be worried about that 27% in 2006. That was essentially an artifact. That was due to the implementation of Part D, the Medicare prescription drug benefit, that increased costs. But you can see that the next year, in 2007, our rate of growth was 1.98%, and then we went up to 4.9. We've been trending all the way down continuously now, where in 2013, our rate of growth was 0.35%. And that is once again unprecedented in the past 50 years. It's the lowest rate of growth since the Medicare program was established. The red curve shows the medical CPI growth, which has remained constant. So Medicare growth is really declining compared to healthcare growth in the economy at large. And that's a positive sign. And that's not just due, as I said, to economic changes, because if it had been due to economic changes, we would have seen a change in Part B spending. It's the physician side, which is what people often is most affected by discretionary spending, and that didn't happen. So it's Part A decreases that are primarily hospitalizations that's primarily driving this decrease, and that means we're delivering care much more efficiently. Now let's go to the next slide, which talks about our reduction in all-cause readmission rates. And you can see this started in January of 2010 over on the left. And Medicare readmissions had been averaging a little below 19.3%, 19.1%. And then we started to announce in October of 2011 our readmissions reduction program. And even before the readmission reductions payments kicked in, we started to see the rates decline as hospitals really started to focus on reducing readmissions. And you can see we've gone from an average readmission rate of 19.1% all the way down to less than 17.7%. And that is a significant percentage decrease in readmissions. Let's now go to the next slide that shows the national bloodstream reduction in infection rates. And you can see since we've started the initiative to reduce central line associated bloodstream infections, or what we call CLABSIs, we've reduced them by 41% over the last 6 quarters between 2009 and 2012, which is significant. That's in over 1,000 ICUs, 41% decline in central line infections from 1,900, that's rather 1.9 to 1.1 CLABSI per 1,000 central line days. So very significant 41% reduction, which has saved thousands of lives. Next slide shows how hospital-acquired condition rates are improving. And our preliminary data shows that overall, we've reduced hospital-associated complications, hospital-acquired conditions by 9% overall. In many areas, we've dramatically dropped the rates of harm. And you can look at the bottom here over on the left. Ventilator-associated pneumonias have been reduced by 55%. Early elective deliveries have been reduced by 52%, which leads to better birth outcomes and reduced prematurity. Obstetric trauma rates are down 12%. Venous thromboembolism complications are down 12%. Even falls in the hospital and trauma associated in hospitalizations is down 11%. And pressure ulcers are also down 11%. So you can see we're making significant progress. A lot of this progress is due, if you show the next slide, to the work of over 3,300 hospitals that are participating now in our partnership for patients. Actually, over 3,500 hospitals are now participating, and that's well over 93% of all U.S. hospitals. You can see the top line, the solid blue line, shows that when we initiated the partnership for patients back in September of 2012, we started with 40% of hospitals signing up, and we've now doubled that to well over 93% of all hospitals. The second middle gray line, or light blue line, shows that over 64% of hospitals are actually improving in 5 or more, reducing 5 or more hospital-associated conditions. And the bottom dotted line over on the right shows that 1/3 of the hospitals are already achieving the benchmark expected status on 5 or more hospital-associated conditions. So you can see we have been making an incredible amount of progress over the last 2 years. The next slide is a multicolored slide that shows a little bit about how beneficiaries, patients with Medicare, are using some of our transparency markers to select better quality plans. And we now have a 5-star rating with Medicare Advantage plans. That's what we call MA plans. And we have a 5-star rating just like you have with hotels. And you can see that the red line at the top was 4 stars. And when we implemented that in 2009, we actually barely had any 5 stars at all showing up. The 5-star plans have remained relatively constant, but you can see that more and more beneficiaries, as we're going to the right to 2014, 55% of beneficiaries are now picking plans in the Medicare Advantage program that have 4 or 5 stars. And the 2-star plans are not really attracting many beneficiaries. So once again, consumers are voting with their choices when we give them information as to how to rate various health plans based on quality metrics. So let's talk now just a bit about patient safety in a little more detail, which is the next slide. And we define patient safety as the condition or act of freeing patients from the risk of harm, the injury or loss that's inherent with their interaction with the healthcare delivery system. In other words, as you know, going into a hospital can at times be a risky business. So we want to improve the safety of everyone that interacts with the healthcare system and make sure that any morbidities they have are associated from their own particular disease problem and not any harm that we have caused. And of course, for those of us practicing medicine, the Latin admonition, primum non nocere, meant first do no harm. And that was established by Hippocrates 2,000 years ago. So we still need to make sure that we help our patients more than we harm them. And we are taking concerted efforts to do that. Let's go to the next slide where we make the case for safety. Right now, medical harm is the 4th leading cause of death in the United States. Over 100,000 patients, as you heard. Actually, that was a somewhat outdated figure. That came from the Institute of Medicine in 2001. It had a report that Where is Human, where they said 99,000 patients had died of avoidable medical errors. If you added the Centers for Disease Control figure of 100,000 patients a year getting healthcare-associated conditions that cause their demise, I should say healthcare-associated infections, that's up to 200,000 patients that died needlessly. And we thought that was enough, but recent studies out of Harvard School of Public Health are showing that perhaps we underestimated, perhaps the Institute of Medicine underestimated. There's been testimony in front of Congress recently that the estimate is possibly up to 400,000 patients that died unnecessarily due to medical harm. On any given day, 1 out of every 20 patients in our American hospitals is affected by a hospital-acquired infection. An Inspector General GAO report shows that chronically ill patients with Medicare, 22% reported significant error in their care. 1,800 people in nursing homes die each year from falling out of bed and falling that could be prevented. And as I mentioned before, almost 1 in 5, almost 20%, as you heard, 19.5% of Medicare hospitalized patients had been readmitted within 30 days, but as you saw, we are making progress of reducing unnecessary readmissions. The next slide just shows again, in any given day, 5 patients still in this country have operations on the wrong side of the body. and 40,000 patients may have something go wrong in their care. Now, many of these don't lead to harm, but they may be what we call sentinel events, and they show that there's a system that needs fixing because something could lead to harm. And 10,000 people have a complication from a medication. Now, let's go to the next slide. Talk specifically about healthcare-associated infections, and we're talking specifically about bloodstream infections, urinary infections, pneumonia, and surgical site infections. There's over 1.7 million HAIs in hospitals a year, and that's just in hospitals. And the burden in other healthcare settings, such as nursing homes, is yet to be determined. As you see, the figure of 99,000 deaths per year, I've suggested that that may be much higher, and that runs up to $33 billion in added healthcare costs. If we could implement what we know and preventing healthcare-associated infections, believe we could reduce 70% of those if we were able to implement all the procedures that we know could help reduce healthcare-associated infections. Now let's go to the next slide, and let's talk about some of the provisions in the Affordable Care Act that are leading to the improved quality and efficiency of care. Once again, we're emphasizing prevention and emphasizing primary care. We're looking at expanding our measures to focus on outcomes and efficiency, not just process of care. And we're expanding the settings that were covered by quality reporting and public reporting systems and value-based programs. Virtually all programs reimbursed by Medicare now or within the next year or two will have a value-based purchasing component associated to the payment. In value-based purchasing, I'm going to focus primarily on the hospital value-based purchasing system, although we also are implementing physician value-based purchasing, and that is ongoing now and will be completed and fully implemented by 2017, when all physicians will also be have payment based partially on the quality of care and the efficiency of care they deliver. So we're going to address in some of these areas that are outlined in red, the hospital readmissions and healthcare-associated conditions. We'll talk a little bit at the very end about the accountable care organizations and some of our Innovation Center pilot studies and bundled payments that are in the works and ongoing to transform healthcare delivery. The next slide talks about our pay for performance and the 10 areas that we're focusing on. And once again, I showed you that graph of the hospital partnership for patients. And part of that initiative is in all states we have hospital engagement networks. Often the hospital associations, the quality improvement associations, et cetera, are working together to focus on these 10 areas and reduce the adverse effects of drugs as well. We're looking at reducing the catheter-associated urinary infections, central line bloodstream infections, falls, obstetrical trauma. You've seen some of the results we've already achieved: pressure ulcers, surgical site infections, venous thromboembolism, the ventilator-associated pneumonias, and the preventable readmissions. And you've seen already, I gave you some of our preliminary results. The next slide, we actually start talking about the hospital quality reporting program, which forms the basis for our hospital value-based purchasing. But we started the hospital quality report program back in 2007 as a result of the 2003 Medicare Prescription Drug Improvement and Modernization Act. And initially, we added incentives for hospitals to report the quality of care. And those measures were displayed on the Hospital Compare website. And over 99% of all American hospitals are successfully participating in the hospital quality reporting. Now, that gives us the basis to implement Hospital Value-Based Purchasing Program, which is on the next slide, and the Affordable Care Act implemented the Value-Based Purchasing Program. That was based on the quality reporting infrastructure that we had developed, and this was the next step to promote higher quality care for all Medicare beneficiaries. And I would say that there's a spillover in any hospital to all beneficiaries of patients, not just Medicare beneficiaries. It rewards better value for patient outcomes and innovations instead of just paying hospitals for volume of services. What's happening is all hospitals are initially putting in 1.25% of their expected DRG payments into a risk pool, and then there are winners and losers. That risk pool will be expanded up to 2% annually by fiscal year 2017. So put 2% in, and then you have a chance of getting more money back, or you have a chance of losing that money that you put in if you haven't improved your quality. Now, let's talk a bit, next slide talks a bit how we're changing the weighting of what we're measuring and what we're paying for in the hospital value-based purchasing. Over on the left, you can see that initially we were focusing a lot on processes of care, and we were that was weighted at 70% in the hospital value-based program. But you can see as we move towards fiscal year 2016 that the process of care measurement as a function of your value-based purchasing payment is going down. What's going up is your patient experience of care, well actually that's staying relatively constant, 30%, and then going down to 25%. But what's going up is we're looking at paying for improved outcomes. So you can see that over time, the weighting for patient outcomes is going from 25% to 30% to 40%. And also we are weighting efficiency in the next fiscal year, where 20% of the hospital payment will be based on their efficiency of care, and that'll go up to 25% in the next year. Now the next slide is a diagram with a lot of colors here, and this actually shows the current 2005 fiscal year finalized domains that I just talked about in the last slide. You can see that we're paying for outcomes at 30%, patient experience 30%, process of care, as I said, we've reduced to 20%, and efficiency is 20% as well. In the dimensions of the patient experience, patient-focused care, hospitals are being graded by the patients on nurse communication, doctor communication, pain management, hospital staff responsiveness, cleanliness, quietness, discharge instructions, and an overall rating. You can see that our process of care measures are many of our hospital quality reporting measures. The AMI, the acute number one is the heart attack fibrinolytic therapy, speed of receiving that therapy. You can see the SCIP, SCIP, numbers 6 through 10 are the surgical infection prevention measures, and number 4 is the blood cultures. Actually, that measure is being slightly changed in the future. And you can also see the outcome measures in the yellow are the mortality rates associated with myocardial infarction. Mortality rate, 30-day mortality rate with heart failure, pneumonia, and then we have the patient safety indicators that I'll talk about in a minute. The central line bloodstream infection is being added this year. And then you can see we have the efficiency measure there in purple, which is the Medicare spending beneficiary measure. And that is incentivizing hospitals to be more efficient in the care they deliver to Medicare beneficiaries. Now, the next slide is slide patient safety, hospital-associated condition domains that we'll talk about in just another slide. These are domains of care that will that go into forming our hospital-acquired conditions reduction program. And you can see in domain 1 is the AHRQ patient safety indicators, pressure ulcer rates, pneumothorax, iatrogenic costs in hospitals, central vascular infection rates, pulmonary embolism, postoperative sepsis, infection rates, accidental punctures and laceration rates, and those are being measured in our hospital-acquired condition reduction program. The other domain, the next slide, domain 2 is the CDC hospital-associated infection measures. And once again, you see the central line bloodstream rates for 2015 onward. The CLAUDI, the catheter-associated UTI rates, the surgical site infections for colon surgery and abdominal hysterectomy. You can see that MRSA rates are also being included from 2017 on, as well as Clostridium difficile rates in 2017 onward. The next slide talks about the hospital-acquired conditions reduction program that I just gave you those domains. I apologize, I probably should have had this slide first, but I'm pretty good at shuffling cards and shuffling the deck, so I'll have to rearrange this in the future. The hospital-acquired conditions program is based on public reporting of the hospital-acquired conditions in Hospital Compare by 2015. And we will make adjustments to the payments for hospitals according to the Affordable Care Act, Section 3008. We will reduce hospital payments by 1% for those hospitals that are in the top quartile, in other words, that have the highest incidence of hospital-associated conditions. In other words, those hospitals that perform the worst in hospital-acquired conditions will have their DRG payments reduced by 1%. And I've given you the final rule, the inpatient payment system that gives you the exact methodology of how those payments will be determined. The next slide, we talk about, as I said, the readmissions reduction program. And once again, beginning in fiscal year 2013, we implemented a reduction for hospitals that have readmissions that exceed the expected amount of readmissions that we would expect based on the severity weighting of their patients. So excess readmissions, hospitals are penalized. And these were specifically looking at acute MI, heart failure, and pneumonia readmissions rates that were the National Quality Forum standardized readmissions measures. The next slide talks about the payment reductions or payment adjustments that are for the readmissions, excess readmissions for heart failure, MI, and pneumonia. And you can see that in 2015, we will also add 2 more conditions to the readmissions rate reduction, which is COPD and total hip and knee arthroplasty readmissions. So these will apply to the hospital-based DRG payments. And as I said, it started for discharges beginning in October 2013. Back in fiscal year 2013, hospitals could receive up to, but no more than a 1% reduction. But you can see that reduction ceiling is increasing, so that in 2015, hospitals might receive up to 3% reduction if they had excess readmission rates. Now, they don't have to receive all the way up to a 3% reduction. They might get a fraction of that amount if they're expected, if their readmissions exceeded the expected amount by a smaller amount. And once again, the rulemaking methodology is discussed in that Federal Register notice that I provided. Why are people readmitted? Oftentimes suboptimal medication regimen, suboptimal treatment the first time. They end up coming back to the emergency department. I'm an emergency medical specialist. I've seen lots of patients come back in with congestive heart failure, probably inadequately treated the first time. Oftentimes the patients, the systems don't support effective transitions of care. There's unreliable information. Sometimes the patient's medications aren't transmitted timely to the physician who will be taking care of them during their outpatient care, or the patients are not hooked into effective follow-up. So a lot of the times what we need to do to reduce readmission is establish a better coordination of care between the various transitions of care and set up better support systems in the community to do that. The next slide talks about transitional care coordination and handoffs and handovers so that we don't drop the baton. And when we drop the baton, obviously the patient ends up coming back in the hospital. And this obviously, care transitions are a significant patient safety issue. They're a significant patient safety issue in the hospital when we hand over care, even in the emergency department. I was always a stickler that we made rounds on every patient. When I was coming off a shift, that I made rounds to the physician coming on the shift, and the patient knew who their new doctor was, and we actually went to the bedside and let the patient know that I'd worked my 12 hours in the ER, and their doctor was the doctor who I'd introduced them to. And they knew that the care was being handed off to that new doctor. The same thing applies when we discharge the patient from inpatient to outpatient care, or inpatient to skilled nursing care, step-down care, etc. And hopefully electronic health records and interconnected records will help this as well. The next slide is basically a summary of key messages about value-based purchasing. As I've said several times now, we don't want to just pay for volume of care, but we want to pay for quality of care. And so instead of a payment that asks how much did you do, the Affordable Care Act clearly moves us towards paying and asking how well did you do, and more importantly, how well did the patient do. That's basically what it's all about, is hopefully when a patient goes into a hospital, they have a better outcome and are healthier than when they leave the hospital, if at all possible. I just want to take a couple of seconds to talk about some of the exciting work we're doing in our CMS Innovation Center, which is the next slide. And basically the Innovation Center is to test models of care that reduce expenditures, but improve service deliveries and enhance the quality of care. And this was implemented under the Affordable Care Act. The next slide just gives you an example of many of the models that we are currently testing and have on pilot study, innovation models that are being run from our Innovation Center. Many of these you know about, the accountable care organizations and the Medicare Shared Savings Program, the Pioneer ACOs, etc. Looking at partnership for patients, community-based care transitions, Million Hearts, etc. Bundled and for care improvement as well, and primary care transformation, such as comprehensive primary care initiatives. I have a map on the next slide that just shows you across the country where a lot of these innovative models of care are currently being carried out. The next slide just talks a little bit about accountable care organizations. Accountable care organizations are a new approach to healthcare to deliver better care, improve population health, and they coordinate care for services under both Medicare Part A and Part B, the physician and the hospital component, and that encourages investing in infrastructure and redesigning care processes. There are many different paths towards forming an ACO, and you can see that we have both advanced payment initiatives, the Pioneer model, as well as ACO learning development sessions to get people started on ACO development. The goals of accountable care organizations are listed here. Once again, improve safety and quality, shared accountability, coordination of care, and better health and lower costs. And the accountable care organizations are preliminary results and success. We've developed over 350 ACOs, serving over 5 million Medicare beneficiaries currently, and over $388 million of savings was combined in year one of both the Medicare Shared Savings Plan and the Pioneer ACO model. The Pioneers generated shared savings and lower cost growth, just 0.3%, and they outperformed published benchmarks on 15 out of 15 clinical quality measures and all four patient experience measures. Finally, the last slide gives you the website for more information that you can go to our website to learn about these initiatives. And that concludes my talk.